good to be here with everyone. I think I'll start off by saying that it's good that everyone just had a moment of a break because we are about to dive into the world of financing. And so you just heard some really amazing information, but when we talk about what it means to talk about financing of rare diseases, it is complex, it is very in the weeds, and it is very individualized and specific. It doesn't matter how national an approach can be or international when we talk about financing. There still tends to be a very individual way to how things are paid for. And that tends to be a cause of immense frustration to many. And so we are going to talk a little bit more about that. But I will give an initial disclaimer, which is all to say that my knowledge of the rare disease financing space came up from my time working for Senator Orrin Hatch, who was one of the authors of the Orphan Drug Act. And so, being able to learn directly from him, being his staffer on FDA policy, knowing his history and his motivations and his philosophy, that sort of framed my own understanding of what we can do in the promise here. And when you hear such motivational speakers, as we've heard, about what it is that rare diseases are and what the future of research, the future of access to treatments can be, it makes you very excited. This is the sort of work that gets health policy staffers on Capitol Hill very excited because you can see that there is a problem, and then when there is something that can actually change someone's life, it is not, the same thing as a chronic illness, which has its own set of benefits that can happen. But you have, current example, and we've heard a few others, when you actually have a treatment for a young boy with Duchenne's muscular dystrophy who would have had a death sentence and now can walk and live a normal life because of a treatment, that is exciting. People that work on Capitol Hill are very excited about the promise that these bring. They also bring a large price tag, and who pays for them varies a lot. And so we can dive a little bit further into that. But I want to at least start off by explaining to you that I'm not going to dive into the numbers and sense solely of this is how much this drug costs or this is this approach. I'm going to explain financing a little more globally. The next slide, thank you. So we're going to talk a little bit more about how there are three main aspects to what financing looks like, regardless of who the payer is. The first being that access is complex. The second being more about that these roadblocks that exist, regardless of payer, exist for a variety of reasons. Depending on your vantage point, it is a way to make sure that a drug is provided and it is being used clinically in a clinically appropriate way. Or it is an impediment to someone receiving care, and it is very annoying. Or oftentimes life-threatening if it is delayed too long. So there are perspectives to this that create some of this additional uncertainty when it comes to how payment is determined and when payment applies. There's also an element that I think is really important, and this is where I'll dive into a little bit more of the financing models and that we've seen today, that there's a desire to finance at scale. When someone has a rare disease, there's this desire to say, okay, we know it's a rare disease, now we can pay for it. That doesn't exist. There are an innumerable number of models. I will try to outline about 7 of them very quickly. But those financing models are subjectively utilized, and they don't keep up with technological advances. Some of the technology you've heard about, some of the biochemical changes, the biomechanical changes, the engineering that goes into the development of these treatments is very exciting. I will tell you all that financing systems are not nimble. There is nothing nimble about them. When people talk about what can move fast, it is laughable when you can hear that administrative action from an agency is faster than Congress when it comes to changing a financing system, because neither of those things fill you with good, happy feelings, because they're both very slow. So trying to create a system that can respond at the pace of innovation is difficult, but not impossible. There are optimists out there. That's why we work in rare disease. So we'll leave this up, and I'll dive a little bit more into each one of them. So when we talk about access, it's important to know that the diagnostic journey that has been outlined really is difficult. There is stress. There is stress for the individual. There's stress for the family. There's stress for the practitioner and their professional teams. And oftentimes, the difficulties for the families can be quite debilitating. You're talking about a care team that is not just a clear provider. You're talking about the world of how social services also play a role. We've heard about education's impact with rare disease, but you're talking about every type of therapists, you're talking about additional local supports, you're talking about different networks of professionals that can help guide someone with understanding which of the innumerable specialists that they are speaking with also connects to their pediatrician, which connects to both their center of excellence that they're going to, but also a local provider in case they have to go to an emergency department or urgent care. And you're trying to make sure that if they need any mental health care to accommodate some of these other changes, that that's not falling through the cracks, and that all of these systems, in fact, are being entered into a medical record that can be provided to any of the actual providers in this team. And if you think that that actually happens, I applaud your optimism. So it is a very difficult process, but this additional element of family makes a huge difference because we've seen that through genetic testing, there have been more manageable elements because there's a better sense of expectations. We've all heard today that there's always a maybe as an option, but the idea that there is a maybe as opposed to a no, or I don't know, creates a sense of hope that lets people want to continue down this road. The financing of a rare disease treatment first requires the ability to actually know what the rare disease is. And it sounds like a very basic step, but as you've also heard, it takes a very long time to understand what the rare disease is and what that treatment plan looks like. Frequently, the treatment plan for years or decades is a variety of measures to treat a symptom, and trying to make sure that you have symptom management that can be covered is difficult because of who the payer is, and we'll dive into that in just a moment. Usually, going through the process, that diagnostic journey, can cost many, many, many thousands of dollars before you even get to the point of knowing that you're actually treating something that will help a symptom, or hopefully something that can actually address the underlying condition. So it is expensive. Insurance, regardless of if it is public or private, meaning Medicare, Medicaid, or commercial insurance usually covered through an employer. There are exceptions, there are other changes. Some people will pay for certain things privately, there are other carve-outs, but big picture, we're talking Medicare, Medicaid, and private commercial insurance as the major payers of services. And that gets even more in the weeds as we talk about what it means for kids, because Medicaid covers about 43% of all kids nationwide, but for kids with a rare disease, you're at a greater than 50% number. That makes it the largest payer, which is both a really good example for how we analyze this, and also an element that makes it even more mind-boggling. My job, my day-to-day job on Capitol Hill, while the Committee on Finance might make you think that I work in the finance industry, Congress works by jurisdiction, and we have not just the Internal Revenue Code, but the Social Security Act, which contains Medicare and Medicaid and the Children's Health Insurance Program. So my day-to-day job is to be the Medicaid guy. I know Medicaid policy. In order to understand Medicaid policy and how it applies to coverage of what gets covered and paid for, you have to know that there are, in fact, 50 state Medicaid programs, a Medicaid program for Washington, D.C., and 5 U.S. territories. There are 56 different programs. Every program operates with a completely different set of rules as it relates to how something can be covered. Some of it might be federal, and there is such a thing as the Medicaid drug rebate program that covers outpatient drugs. But how those drugs are applied is different in every single one of those states. Every state has their own pharmacy and therapeutics committee. They have their own review boards. They have their own treatment guideline plans that are supposed to consult with the rare disease experts, because it is also laughable that every state has their own person who is keeping up with the research and learning the next 7 to 10 rare diseases that come up every week. So that is something that you have to keep in mind when you're trying to think, how can these systems make sense of everything that is out there, as opposed to the status quo, which is important to outline. The reason there is a Medicaid drug rebate program is to say that there is an agreement, if you will, between a drug manufacturer and the state, that the state will cover everything from the manufacturer, so the manufacturer is thus happy about that, as long as there is a rebate. The Medicaid gets not just a good price, but the best price. There's a little asterisk because it's healthcare, there's caveats everywhere, but big picture, Medicaid must get the best price on the market. So as long as Medicaid gets that best price, which could be from a statutory rebate, or it could be from any other price paid elsewhere in the marketplace, that guarantees that a drug is covered. That doesn't work when you're talking about a drug that is hundreds and hundreds of thousands of dollars or multiple millions of dollars as more of these durable treatments start to come to market, because regardless of patient size, there's going to be some challenges. Patient population size, I should say. So while this is broadly a good deal, and Medicaid is supposed to get this great benefit, there are some things that make you wonder. When anyone who works in this space, again, I like to believe is an optimist. It doesn't mean we don't have nightmares. For me, it is the fact that the Medicaid drug rebate program, which is the pharmacy benefit in Medicaid, is an optional benefit. All 56, no, that's not true, actually. In the territories, it's unique. So all 50 states and Washington, D.C. cover drugs. They cover this pharmacy benefit. It is not crazy that if we don't update our systems, states which have balanced budgets will have to face financial pressures and debate if they have to limit access to drugs, create their own plans, and drop a broader-based pharmacy benefit. It might sound far-fetched. I think it is if you say that's going to happen in the next 5 years. But if you think it couldn't happen in the next 10, if we don't get our act together and figure out a way to finance these therapies, I think, history creates a little bit of a better understanding here. For those of you that don't know your Medicaid history, Medicaid was created in 1965. The pharmacy benefit was created in 1990 and really kicked into effect later in the 90s with some other changes in the 2000s. That took 35 years from the creation of a program to the realization that there should be an outpatient benefit that's a part of this. We are now, from that point, 33 years. So who knows what change is coming next? But we have to be aware that when a system that is based on a variety of mandatory and optional benefits exists, it creates a standard that has some fungibility. And I use Medicaid here because private insurance many, many times bases their protocols on Medicaid. And there is a decent number, roughly 10% of those with private insurance still rely on Medicaid as a secondary payer, or Medicare. Those individuals need the backstop that comes from public insurance because the costs of this population are great given the complexity of the condition. So I say all this not to scare you, but to also make you know that access plays a huge role. One last example of why access can be complex and why insurance plans, perhaps on the private market side, are going to be worried about this. In the early years, I believe in 2017, early years of the ACA implementation, which went into effect in 2014, the marketplaces in Iowa had a conundrum because it was determined that there was one person who had a rare disease, an adult, not a child, who had a condition that costs about $1 million a month. That's $12 million a year in a marketplace which is relatively nascent. In order to, this person came to everyone's awareness, got treated. There's rules of the road that mean you can't drop someone, right? Everyone was aware of those components. This person got coverage. The plan came out and said they were raising rates for that year 10% for everyone in the plan solely because of the costs of that one patient. That doesn't make an insurance market giddy, nor does it make the idea of what can happen for bringing more people into that plan excited, and the following year, that plan dropped out of the Iowa marketplace. That is a problem when we're trying to make sure that the financing mechanisms ensure coverage. I'm focusing so much on access as opposed to just the straight financing models because the whole point of having financing models is that you actually improve access to care. And you cannot have one without the other. So I think if we shift a little bit to the second sort of aspect, this tenet, that there are going to be payer roadblocks, understanding why is important. It doesn't mean everyone agrees, but they are quite important when we think about how patients navigate the system that is before them. So I have yet to meet someone in the rare disease community, whether they are a provider, a patient, a family member, a manufacturer, who hears the words prior authorization and smiles, who thinks a happy thought. It is, in fact, Similar if you talk about a fail-first model, where someone has to try a lot of things before they can get the actual treatment that the provider wants them to have. They're shaking heads. There's like, oh my gosh, I've dealt with this before. We all know in the health community that these are sources of frustration to many. But not every prescriber has a specialization in rare diseases. And there are people out there that will prescribe things that are not the correct course of action, because not everyone seeks treatment or receives treatment where they need to for their condition. From the payer perspective, these are essential steps in order to make sure that we aren't abusing the system that we have, and that we actually make sure that care can be provided appropriately. That does not mean that they should be used freely in the way that they so are, so that utilization controls become viewed as a control on utilization to the point that someone can't get care. However, we have seen that happen with these more expensive products coming to market that are in the durable therapy bucket, which is sort of a safer catch-all than gene therapy frequently, but I also use gene therapy interchangeably, and you will hear that as well. These are incredible products. They are life-saving products. They can do so much. On Capitol Hill, we are free to say things that others can't in the manufacturing space and sometimes in the provider space. We can call things curative because we don't have to caveat it, because we are only accountable to people that want to cure. So it's a sense that we can have this potential that's out there from these products. And it's really, really incredible when you think about the good that can come. However, the number of rare disease steps and preferred drug lists and specialty tiers as tools that are used through insurance, regardless of if it's private insurance that people are familiar with, or used through either a state-based plan through fee-for-service Medicaid, or a managed care plan that operates and has the contractual obligations to handle the Medicaid side of a patient's care, or a Medicare plan, whether it's Medicare Advantage or you're talking about fee-for-service Medicare. And I have to keep giving all those caveats because, again, it is different every single time what is used and what is covered and how it can be provided. But there are these steps that are taken across the board, regardless of what someone needs in their financing space. So I will say that too often, as a staffer on Capitol Hill, I have heard stories of state Medicaid programs that block access to gene therapies solely because of the fact that they are very worried about the expense. It is one of those things that sort of haunts me when you think about the promise of people that actually want to care for the broader population. But we find ourselves caught up in this cycle of budgets, regardless of who you're talking about, that try to focus on how to take limited dollars and apply it to the most people that you can. Perhaps a more utilitarian argument. That always goes badly for individuals with rare diseases. And that is why it's very important that there is an opportunity to finance in a non-traditional way. And that is the direction that we have seen when it comes to the treatment options that are available and what states are working towards, especially in Medicaid. Because Medicaid will drive what happens in the private market. The examples that we've seen today are one-off. They are not yet at scale. So on this third point, which I think is worth investigating a little bit further and diving in a little bit deeper, there are a number of different approaches to financing. We could call one the value-based arrangement, value-based agreement, value-based contracting. You could talk about a value-based purchasing arrangement, an outcomes-based arrangement, great. All meaning approximately nobody knows. You can say a lot of things without them being defined, and people think that you are very, very smart. But it does, in fact, mean nothing if you don't have anything to back it up. You need to know if you say a value-based agreement. Are we talking about paying for something over time, like a mortgage? Is it the base amount that is now allowed? We have to make some changes to the rules, whether it's regulatory or statutory, and frequently in this case it's statutory, which, again, big effort, costs money, goes through this whole how a bill becomes a law process, and yet also necessary here. But if we make that conversation happen, and we have this discussion on are we paying over time, is it just to do it as a mortgage to make it cost a little bit less? Are we paying for something as a subscription? Hepatitis C treatments have undergone a subscription model, sort of, referred to broadly as the Netflix model in Louisiana. Washington State has used it as a way to say that they have a subscription for the product, and anyone who needs it can get it. That is one model. It doesn't work for every drug. Again, it doesn't work for every condition. A condition that we're talking about with a couple hundred, a couple thousand individuals a subscription is not going to work for every state when you're lucky if your state has, 2 people with this condition. So you have to think more creatively. You also have people who are going to say that all of those models are bad because they do nothing about the cost of the drug, right? The drug cost is still the drug cost. You're just breaking it down in some other way. So then you start talking about what does it mean to have value. Setting aside who determines what value is, because I could talk for an hour about what that means in different approaches globally as to what that means and how, regardless of everyone's thoughts on what they are, the United States is still the place you go when you have a rare disease and when you're looking for something that actually provides you access to a treatment. It doesn't matter what every other system is trying to do, and I've spoken to many of them. Benefits and blessings of Capitol Hill. I've talked to a lot of other countries' approaches too, because Medicaid looks a lot like some other European models of care when you think about it. And they all look to the US and what the US approves and what the US covers without a sense of how it's paid for, because we have a very different system here. So if you start talking about value, are you talking about coverage of a product that if a certain clinical and or surrogate endpoint is met, you can provide full payment? If it's not met, can you provide a reduced payment? Or do you have a contract that says, we believe so much in our product, it is a gene therapy and it will cure you? And if it doesn't, you can have a non-payment. That is like a controversial statement in the world of pharma policy when it comes to rare disease, because saying we will provide a drug and if it doesn't work, then it's a guarantee. We do not have 100% cashback guarantees in healthcare, and this is the creation of one that some states would like to try, but it can't happen without some additional federal rules. There has been an attempt to do that administratively without Congress through this concept of having, I mentioned a best price. There's this idea through regulation that it's possible to have multiple best prices. Your best price on the market outside of a VBA and your best price available with the VBA. It's an interesting approach. It's creative. It's also, I think, the only healthcare rule that was proposed in the Trump administration that has actually been advanced in the Biden administration. There are not a lot of those. That might also not be shocking, but this is one that has gone farther. Flip side, it hasn't been used. Why? Because it's hard. Because now you're discussing what does it mean if you have a best price where the best price in Medicaid is 0. Or there's a product on the commercial market that someone wants to try to use to offer with this all or nothing approach, and the outcome is it didn't work, and then they pay 0. Well, you may have fixed it in Medicaid because you have your Medicaid best price still exists, you're not hurting the underlying Medicaid program in that regard, but now you have this issue in Medicare where you have to actually, think about how drugs are priced in Medicare, and it's based on your average sales in Part B. And if your sales are 0, let me talk to you about averages. It doesn't work well. So it creates this conflict of how Medicaid interacts with Medicare. There are requirements on Part D of Medicare drug coverage. In order to have a drug offered in Part D, you have to have the same drug available in Medicaid. These are all interconnected systems, and commercial markets won't do any of this if they don't think there's clarity, because they're not going to cause an issue with their access to the Medicaid market by having a best price problem. If you don't feel confused, I can try again, because this is not easy. And those aren't the only ways. There's always an other category. There's always a one-off approach. There's a grant-based way to finance something. There's a way to figure out another system. But when we look for sustainability in how we can actually finance these systems, it's very clear the status quo doesn't work, that you have to have change. Durable therapies for rare are the current focus, but it's also a problem because as it becomes so difficult, as was just outlined, that gene therapies are harder than people thought, the idea that we can turn to durable treatments that are more effective for chronic illness is starting to catch people's eye. As a Medicaid staffer, I will always be the first to say that talking about gene therapies for Medicaid was the first goal. And then everyone realized it was hard, and they started to talk about how do we pay for them in Medicare. We're having the same situation. We're talking about rare disease structures is like the whole focus. There's 10,000 rare diseases. The opportunities are growing. We have so much energy here, but it's hard to think about small populations, expensive products. How do we live within the rules of the road? What if we start to see more investment elsewhere and we start to see it more in changes on the chronic side? I'm not here to create some dichotomy of fighting between rare and chronic, but I think it is a lost moment if we don't continue to build on the momentum that exists in the rare space to make sure the financing systems can keep up. And unlike a lot of the good work that has been done in the research and development community, from the provider side, from the manufacturer side, from so many of the advocates and families, these changes require an act of Congress, a literal act of Congress. And so there has to be energy behind them to make sure the financing systems can respond. So it's not the same. I'll start to wrap up here by saying that there is not some sort of guarantee that you have a bundled payment for your medical and your social services. You can tie it up in a bow and say everything you need is covered at this rate, go and solve the problem. That doesn't exist in the rare space. There are opportunities to try to think about these things more creatively, and we need all of this additional sense of whether or not it's regulation sometimes, but not too much, because you don't want a chilling effect to occur, where manufacturers feel like they are under too much burden. They don't want to invest in this anymore because it's become too difficult. Or legislation, which I would argue is the likely scenario for what we need in order to be successful here. So avoiding all of those components also means that we are very clear that the US system has a way to pay for this with people who understand how to pay for this. All three of those points are wrapped up in understanding that we need experts in the room. There need to be experts that are a part of the financing models and not treating the rare disease development separate from the rare disease financing. Because what happens is you have a lot of people that confuse accelerated approval and conditional approval, which is an EU term for those of you in the EMA space, which means that it is a lesser approval. You have situations where drugs come to market and they are viewed as not fully approved. You have gene therapies that go through a variety of pathways that have been bipartisan, passed through Congress, bipartisan through different administrations and advanced through different approaches, and suddenly we have this chilling effect because the regulator on the approval has zero connection to the regulator on the payer. And that is going to create a long-term financing issue in the rare space, in particular, unless we really make it a focus. Because there are going to be billions and billions of dollars spent in this space, regardless of what happens here, if we are successful. And the pipeline, which is growing dramatically from being, tens of new gene therapies in the next few years to hundreds within 10 per year. Regardless of solving this problem, there's still going to be an increasing number of billions spent in this space. If we are spending all of that money and it's not going to who it actually needs to serve, and we aren't actually improving access to care, then we have missed an immense opportunity. So I leave you today by saying that the financing system that we have to create needs to really not delay access. And we need to make sure that when we think about the interplay between all the different public and private payers, it's important that we think about the financing itself as a tool and not just a means to an end.